Well, thanks very much for the opportunity to address you. It is very nice to see that there's a new generation that's going to do the research. In South Africa, we have quite a long tradition of audit. We have a confidential inquiry, the Saving Mothers books, which started in 1998, a Saving Babies audit, which is a perinatal care survey, which started in about 2000, which I'll talk a lot more detail about, and then a Saving Children, which is an audit on child deaths in hospitals. But just to outline my talk, I'm going to give a brief history about PPIP, which is a Perinatal Problem Identification Program, our problems with its implementation, the audit cycle and assumptions we made, the validity of the assumptions, and some possible solutions. So when we started PPIP, and this was in the 1990s, it was very simple. We wanted to have a program which would improve the quality of care in district hospitals. We wanted a single-page data sheet to evaluate each death, and one page to bring the data for the month. We would put it on a computer, and we would get simple statistics, and that would then assist us in our mortality meetings to come up with solutions. As a secondary event, we added the possibility of amalgamating the data, and so that one could ultimately get regional, provincial and country surveys. And we called the system ICA Solution Audit System. It was very simple and perhaps a bit naive, but we wanted to identify all the deaths, allocate a cause to each death, and then look at the avoidable factors, missed opportunities, or substandard care, and by doing so come up with a solution and then work on the solution. In the history, we started with a DOS program, and some of the older people remember DOS. That was tested in 1995 and changed to Windows program in 98, 99. And we did our first national report, which consisted of 27 sites. All the people at this point were volunteers. They were doing it because they wanted to do it in their hospitals. In 2010, we produced the 7th report, which had just under half of the hospitals. And again, this was all voluntary, people submitting their data, and we were producing a report for the country. In 2012, the Department of Health decided to introduce it as part of their program, which each site needed to do, and the 9th report was published last year, in which 83% of all births were audited and includes 95% of all the hospitals. And this is just a graph illustrating how representative the data is. Basically, it's all the hospitals, but there are a number of community health centres that do deliveries. Many of them, and some of them only doing 10 deliveries a month, which is sometimes difficult to get the data from. So if we look at our achievements, what has been done, I think the first thing is that we've been able to continue and expand over 15 years. A lot of things come and go, but this has been sustained. And up until 2012, this was all by volunteers. There was occasional funding, small bits to allow publication and some meetings, but all the rest, it was computer driven and by people working in the hospital sending their data. From the data, we got a country profile, and we were able to very much identify the conditions associated with perinatal death, and also identify very clearly the health system failures. And with that, we were able to create quite an awareness of perinatal death at stillbirths and neonatal deaths in the Department of Health. And in fact, one could stop here and say that's enough. And if you want to do audit, this is really, if you've got this, then you've got the tools which you need to make a difference. And audit itself, as it stands here, is extremely valuable. And it should be done, and should be done just for these reasons alone. And if we look at the data, we can, in our program, we can say where the deaths are, what the mortality rates are. We can look at the causes, and whether they be stillbirth or early neonatal deaths. We can give the birth weights and categories and looking at deaths per hospital per year and so on. And the data can go down to the districts. And we also record all the avoidable factors, which the clinicians record them from the site. So we can build up a picture of the health system failure. So really all this is, and it's not complicated, can be done on paper. It's counting and making numbers, percentages, and rates, and then just interpreting that. And very simple, very easy, and everyone can do it. And again, I just stress this was all volunteers. And essentially, just keeping at it little by little doesn't go backwards. But the actual reason why we did the audit was to see what effect it did locally. We believed that if you identified the problem, you would be able to improve the mortality at the site. And we're all aware of the audit cycle, and we would collect the information. The ICA solution audit system would collect, analyze the data, recommend solutions, and then one would implement the solutions. And there are certain basic assumptions which we used, and I'm sure you will agree with them. The first is substandard care is widespread and present in the general care of patients. It's not specific to the patient that has a poor outcome. So if we examine a few specified cases, the inadequacies found will identify the major problems within the service. Once the inadequacies have been found, solutions can be identified, and the implementation of the solutions to the inadequacies will improve not only the care of the people with those problems, but to all other patients in the service. So this is the basic philosophy of audit. And the question is this assumption linking 2 to 4 true? And that assumption is, once the inadequacies, that's the avoidable factors or the substandard care, the modifiable problems, have been identified and made well known, there will be a self-correction by the people in the team and in the hospital, with a consequent reduction in mortality. So is this assumption true? Well, there's a paper in the International Journal of Gynaecology and Obstetrics with a meta-analysis looking at published studies on audit, and this showed a 30% reduction in perinatal mortality if audit was done in low and middle income countries. But if one looks at the Cochrane review, they felt that there was the effect of audit and feedback was generally small, moderate to small, but perhaps bigger in the lower and middle income countries. But it wasn't regarded as particularly an effective intervention. So if we look at the implementation of PIP in South Africa and take 2008, in South Africa at that time there were 664 sites conducting births, and as you can see, more than half of them were these community health centres, clinics doing between 10 and 30 deliveries a month. Of all these sites, 340 had not started any audit. There were 321 sites that were registered with PIP, that was almost half. And of those, half who had registered, well, basically were no longer sending any data, and the data that where we had trained people, despite the training, they had not sent data. But there were 162 that submitted data to the national database, which basically came down to 25% of all sites and 50% of all hospitals. But this showed us that they achieved audit and feedback. But it told us that doing audit and sustaining it is actually quite difficult. So we wanted to investigate this, and we brought a sample of the 163 sites to a workshop in Pretoria where we did some qualitative research Annemarie Berg was the main instigator and researcher on this. And then after that, they did telephone interviews with another 48 institutions to try and determine what makes something sustainable. And some of the findings are, but before we get to that, we need to understand the concept of change. And so initially you need to create awareness, then the people commit to implementation, prepare, allocate resources, they start doing the job, then they have to integrate it into routine practice and sustain the new practices. And all that's clearly described in the pre-implementation, implementation, and institutionalization phases. We can draw the graph slightly differently on a horizontal line, and then we talking to and doing the focus groups with this large people, all of whom had one way or another managed to send back data. These were the crucial things. Awareness was created by conferences and presenting research at it. Then there were regional and provincial coordinators appointed. The provinces felt it was important that they gave people time to actually do this and go and train others. Leaders were identified, and they were an enthusiastic individual at the hospital. As I've said, at this stage, this is all voluntary. These were people who wanted to make a difference and were doing the work. You had to have buy-in, and that was by individuals and a team. There was computer and software training which was needed to implement and sustain, and that was one of the requirements. There had to be teamwork, collect all the information together, enter it on the computer, and so that was a monthly task that had to keep on being done. And it's no good without having feedback. With feedback, then things could change, and you would empower the mortality meetings. And at the end, there was formalization and institutionalization of various functions. So those were the criteria which enabled the sites that were successful to sustain the audit. The barriers, well, people and all aspects of people, and the people are the same. They can be barriers or they can be facilitators. So it's the attitudes, the team, interpersonal communication, and computer literacy. The system, was there a culture of audit? Was there enough people? What did the management say? And the IT, were there sufficient computers? Were the computers accessible? Did people know how to use the software? And what about education? Were they exposed, or have they heard about it before in undergraduate? And all of these are just interlinked. It's really a mismatch of everything, and it's a very complex system if you're going to get something going and one thing affects another. The health system is not a machine. It's more like a environmental system where you push on something that might get a completely different result at the end. But the key aspects for conditions for implementation and sustainability were leaders, dedicated individuals, support at a national or management level, and having time allocated, buy-in by the teamwork, buy-in by the people in the community at the hospital, and training and being able to do it, have the skills. And this is written up in the BMC Health Services research by Belazan. So if one knows the process of implementation, and you have your barriers and facilitators, and we know the two sides of the same coin, the next thing is, well, did it make a difference? Did we manage to implement, integrate into routine practice, and then make a difference? So we come into the key question, is once inadequacies, avoidable factors, modifiable factors have been identified and made well known, the feedback, there will be a self-correction and consequent reduction in mortality. What happened? Well, In 2014, we had 163 sites where we had more than 5 years continuous data. So these 163 sites had been able to sustain audit and must have had some feedback because they identified the avoidable factors and they were able to discuss it in their hospitals. So if we look at these 163 sites with continuous data, there was 29% had a reduction in perinatal mortality, but surprisingly the rest either remained the same or increased. But there are perhaps many reasons for that. You'll know that South Africa has had a big epidemic of HIV, and some of these sites started in the early 2000s, and when antiretroviral drugs were not that available, so could we not control it better? So we then got 54 sites that had started in 2006 or afterwards when the HIV treatment was more stabilized and drugs were available, and had 5 years or more continuous data. In other words, had reached the point of sustainability. And we found the same. 30% of sites had a decreased mortality, 35 or 70% found the same or increased. Now, why was that? Well, we looked at the 16 sites where there was a clear reduction in mortality and the 19 sites where there was an increased mortality to try and get a clear difference. So the disease profile at the start was the same in both groups. They had the same number of deaths due to spontaneous preterm labor or intrapartum asphyxia or unexplained stillbirth. But at the end, the group that had a reduction in mortality had less unexplained stillbirths. Now that's quite easy to understand, because if you go thoroughly into the death of a baby and you do the audit with care, you'll identify more causes. So automatically your unexplained will decline and your other groups will increase. So that was one indication perhaps there was something wrong with the audit. The second was that there was a clear decrease in numbers of deaths due to spontaneous preterm birth, and this was a significant reduction. And you'll see why now. If one looked at the avoidable factors, we'll deal with the corticosteroids first. In the group where the mortality remained the same or increased, the use of antenatal corticosteroids was still one of the major avoidable factors in the first year and the last year. But if you are able to do research and implement solutions, use of antenatal corticosteroid is something quite easy to implement. You talk about it, you teach about it, it's a drug that's available, and so you should be able to reduce deaths due to that. And clearly, in the group where there was a reduction in death, reduction in the number of cases where antenatal corticosteroids were missed or not used, then there was a reduction in deaths due to preterm labor. So those people doing the audits on properly had made a change. Less patients were being missed who could have got antenatal corticosteroids. And then the other one was use of the partogram. And it was almost pathognomonic. If they had poor use of the partogram in the first year as a major avoidable factor, and they had it in the last year, on the 5th year, as a major avoidable factor, then you can predict that the mortality increased. Because a poor use of the partogram is something that can be corrected and corrected on site. You can train people to use the partogram, and you can train people how to interpret it and then avoid the deaths related to its non-use. So there were clear differences, and the differences we think was due to the quality of audit. So a lot of sites were doing audit and basically ticking the boxes that they've done it and sending the problems on without trying to change things locally. And so what may make a difference? Well, it's the things we've talked about, how the facility is run, the management, restructuring of wards, quality assurance records, staffing, enthusiasm of staffing, the leadership amongst the staff, clinical care, the guidelines, and so on, and outreach and support from other sites. And that's well known, as has been said before. So how do we get there? And I think quite unexpectedly, the answer's been given many times before I've spoken at this conference today. This is a statement from one of the people at our focus groups. If we change people, we can implement change. We are going to put an effort into changing people. And so the way if we want to make audit work, audit is a facilitator. It's not an end in itself. It'll only work if you have leaders. And to get leaders, we need to identify them, train them, and mentor them. Thank you.